Okay, so the first thing outside of growth and development is mental health disorders. So this should be a quick review because you just came from mental health not that long ago. So remember all that good stuff. Remember kids involved in it too. A lot of this will be similar. So this is where we start jumping off into pediatrics. So again, I don't own this material under fair use. I'm providing lecture content only for my nursing students using this content and material. All content within is for educational purposes for nursing students and does not provide medical advice. So, what are we going to do? Hold on, let me make that a little bit smaller. There we go. So, what are we going to do this chapter? We're going to discuss the current trends in pediatric psychiatry, the components of mental health assessment in children and adolescents, learning disabilities and recommended treatments, and reactive attachment disorder and its treatments, 2 mood disorders that you see in kids and their treatments, and 5 anxiety disorders and their treatments, 3 disruptive disorders and their treatments, impulse control disorder, schizophrenia, autism, and 3 eating disorders. So, 3 current treatment modalities right now in pediatric substance abuse treatment, the dual diagnosis in children, and child abuse, assessment, diagnosis, and recommended treatment. So, let's get started. What is a mental illness? So some of the concepts that you'll be doing in this chapter, mood, affect, communication, collaboration, cognition, behaviors, addiction, safety, and stress and coping. So what is mental illness? So especially in children, it's alterations in thinking, mood, behavior with distress or impaired functioning. So a distorted self-view, an inability to maintain personal relationships, the inability to respond to the environment in ways that are in accord with oneself or society's expectations, thought and behavior patterns, impaired judgment, and lack of insight. So, let's go back up. Nearly 20% of U.S. children have mental health disorder resulting in mild functioning impairment. Between 5 and 9% have a mental disorder resulting in extreme functional impairment. Of pediatric hospital admissions, 7 to 10% are for mental health reasons, depression being the primary diagnosis. 60% of adolescents with depression do not receive treatment, and so the ratio to suicide attempt to suicide death is approximately 25 to 1, with a death occurring every 11 minutes. So that's why this is so important to talk about during pediatrics as well. The incidence of mental health is more prevalent in the lesbian, gay, bisexual, transgender youth. So those individuals are specifically on our radar. Okay. So that's kind of that thought process on that. Risk factors for mental health in childhood: physical problems, intellectual disabilities, low birth weight, mental illness, family history, addictive disorder, the family history of, multi-generational poverty, caregiver separation, abuse, and neglect. So the etiology is usually half of all lifetime cases of mental health actually occur by age 14. So genetic, psychological, physiological, environmental, neurologic factors all develop in mental illness in children. So some of it has to do with genes. Some of it have to do with stressful life events, personality and temperament, the gender, depression more so for girls, ADHD more for boys, and the age. So every child responds differently to developmental maturity. The social and environmental influences are huge, right? So nurture versus nature, loving environments. A child is a sponge and it's going to absorb whatever it's in. True? True. So parents that are warm and supportive versus disregarding and neglectful. They have actually done research on babies and their facial expressions and the way that they react to moms that are not there and moms that are there, right? So depression, anxiety, things like that, you appear different to your child and they are going to notice that because babies are very facial recognition, right? So they're going to know right away if this is right or wrong. And in that right or wrong period, that's what they're trying to figure out. Who can I trust? Who can I not trust? Right? So it all goes back day one, trust versus mistrust every time. You can always bring it back to how they were raised as a child. So what we like to say, especially in adults, is what happened to them as a child. Okay? Not what's wrong with you, but what happened to you as a child. So when you talk about ACE scores, the adverse childhood event scores, you need to look that up. You've just gotta. If you don't know about ACE scores, that's all the rage this day and age. ACE scores will remind you a lot about your patient. What happened to them as a child is more important than what's wrong with you. What happened to them as a child tells you a lot more. The kids that are at risk for obesity, depression, suicide, high blood pressure, smoking, drug use, it all comes back to what happened to you as a child. Every time it does. There's no way getting around that. School adjustments, whether that was a positive experience or a negative experience. Social economic status, if you were in poverty or homeless. That's barriers to normal developmental maturity and risk factors for potential developing of psychiatric disorders. Culture, huge. Some cultures do not talk about mental illness at all. Religion, again, same thing. And interpersonal relationships. If you had one positive person in your life, that's all you need. Okay? So you want to be that one. You want to be that pearl in the oyster. You want to be that person that reaches out to that kid and really makes them turn around. It takes one person. If that's not your parent, that might be a grandparent, that might be a sister, a brother, but there's usually one person in your life that makes a difference when you're in the dumps. Okay? When you are in a very negative atmosphere, it takes one person to bring you out. Okay? So ACE scores does not mean you're going to be in jail, you're going to be incarcerated, you're going to be put away, you're going to be a drug abuser, anything like that. So don't worry about that. You have identified that you have high ACEs. If you have identified that you have high ACE score, that means that you're basically have developed that resiliency. Resiliency is becoming something out of that situation. Okay. ACE scores just give us an indication who's at risk, but it does not mean you're in a death sentence at all. So it does take one person to get you out of that, and it's usually either a teacher, a nurse, or somebody close to you. So nurses and teachers really have that wonderful part of being that oyster for that one kid, right? Being that pearl in the rough. There are a lot of diamonds out there that just need somebody to believe in them. And that's where pediatrics and mental health really come together. You've got to be that one person. You've got to be that person that's different for this individual. Maintaining, obviously, boundaries, right? So typically, a teacher at school, it could be a foster parent. Someone is going to get through to that child and make a difference in their life and turn them around. So, neurochemical influences. Let's talk a little bit about that. Neurochemical influences, norepinephrine deficiencies can cause impaired attention, difficulty concentrating, problems with memory, slow information processing, depressed mood, fatigue, psychomotor development delay. So those are norepinephrine. Serotonin deficiencies cause anxiety, panic, phobia, obsessions, compulsions, food craving, and bulimia. So you got to know which one, right? Because when we know what it is, then we can treat it. Do we always have to go to drugs? No. Okay, so a lot of this can be done with CBD, so behavioral therapy, cognitive behavioral therapy, rewiring the brain. Dopamine deficiencies can cause decreased ability to experience pleasure, irritability, aggression, cognitive functioning decrease, and decreased motivation. So we really need to know what is the background of the mental problem. Is it a thinking problem? Is it an attitude problem? Is it a knowledge problem? Or is it something we need to affect in their attitude, right? So some trends in pediatric mental health. ADHD is about 10% in 12 to 17-year-olds. Younger people with mental illness are more likely than their peers to participate in risky behaviors, risky activities. The severe potential consequence to mental illness is suicide. And there are more pediatric participants in drug studies now than ever. So the drugs are getting better and better, and the effect of those drugs. Parents, healthcare providers, friends can reduce the stigma by encouraging youth to experience emotional distress to seek help. So the common thing is don't ask if somebody's committing suicide or has thoughts about suicide or anything like that. Don't ask, don't ask. That is not true. So if you were to take the QPR is question, persuade, respond. It's a wonderful training online. If you ever get a chance to take it and put it on your resume because you're a different kind of person. You understand that we need to question, persuade them to get help, and refer them to help as quickly as possible. People who commit suicide usually had a doctor's appointment or some kind of intervention could have been done in the 2 weeks prior to the attempt. And most of the time, that's a primary care provider that they could have been intervened. So that's why at every office visit, you're asked those questions. It is not that if you mention it, it's going to make it happen at all. We now know that. So the mental status exam, you remember that from mental health. So I don't really think that I need to go over that. But we can always do that during class. So always asking, history of aggression towards animals, arson, running away, family relationships, school temper tantrums, have they been kicked out of school? These kind of things are going to get you in trouble and more at risk for suicide. These are the kids that we're looking for. Okay. So there is a variety of settings for care for mental health. It could be inpatient psychiatry, could be a therapeutic approach with a mental health counselor. It could be also within school. So there are schools for children with mental illnesses, as well as there's usually someone provided to them in the school system, a school counselor that helps with them as well. Especially learning disabilities, behavior problems, stress with kids. There are usually some help available during the school day. Okay. So let's just keep coming through the book. 3 mental health conditions commonly diagnosed in childhood: learning disabilities, ADHD, and behavioral conditions. So common childhood problems include grief and death, parental separation and divorce, sibling relationships, physical illness, adolescent risk-taking behavior, separation anxiety, temper tantrums, school phobia, bullying, growth and development issues, or being abused or witnessing abuse, emotional, physical, or psychological. The nursing interventions that we do to help them through that is provide support, encourage expression of feelings, provide information, answer questions honestly, and assess for anger-related problems and suicidality. Refer the individual and family for counseling. So we always, before we say mental health, we always rule out any physical issues. So if you were to go to the ER and say, I think I'm going to kill myself, they're going to Baker Act you, and they're going to also medically treat you before they send you to mental health. So some of the things that could happen: organic disorders, sensory disorders, medication-induced symptoms. So sometimes our medications for ADHD drugs are methamphetamines, amphetamines. Think about that. So it's a speed drug. So it's going to make them have issues, right? It's speeding up their body. It could also be weight loss drugs, drug-induced psychosis, thyroid abnormalities, intellectual disabilities, brain tumors, lead poisoning. There's a bunch of things that could happen. So we usually do a full head-to-toe physical assessment, laboratory tests, and everything to rule out anything else before we say mental health. Some of the settings for pediatric mental health, again, like we talked about, inpatient or residential treatments, partial hospitalizations, things like that. Residential treatment is very expensive and usually not covered under private insurance. So sometimes caregivers must give up the child custody to the county or the state to be able to have residential treatment. Inpatient psychiatric treatment, I am trying as hard as I can to get a clinical site for this for the future, right? So there is a place called North Tampa Behavioral Health. It's up in Wesley Chapel. It's past the Advent Health Hospital there. I used to go there as Rasmussen instructor and bring my children there, my students there, to see the kids in the unit. So they used to have a unit set aside for military. That went to Atlanta, Georgia. And instead, here locally, they added an additional adolescent unit. So that adolescent unit is locked down and has a lot of kids that are very disturbed. And when you ask yourself what happened to them as a child, they will tell you. Those are kids that are wanting to blow up their school, want to blow up their house, want to kill themselves. So it's a really good learning environment to talk about what went wrong with kids. So it's a very good unit, and I'm trying to get that connection back with that facility for us at Arizona College. So I'm working on that. But in the meantime, there are multiple people in that environment. So there's psychiatric nurse, a psychiatric advanced practitioner, social workers, psychologists, psychiatrists, medical doctor, OT, PT, milieu therapists. There's an addiction counselor there, mental health workers, activity therapists. So a lot of activities are happening in there. Some of the rules around that is that you only refer to patients by their first name. Personal safety, big time. PIN numbers are a code word for confidentiality. Some patients need to be checked on every 15 minutes. You always have to be mindful going in there that you're not bringing anything in that could be used to cause harm to another person. So remember your suicide precautions, remember your suicide precautions, remember your suicide precautions. In that kind of environment, you're always looking for something that the patient says that might indicate that they are wanting to commit suicide. They usually wear a cloth or paper gown, monitoring one-on-one. They're by the nurse's station, finger foods, prepackaged foods, things like that. Assault precautions, you never assign a roommate to them. They're not allowed off the unit, and they're always at risk for escalation. Elopement procedures, you always watch the door behind you. You always monitor the whereabouts frequently. They could wear a hospital gown and slippers once they are eventually deemed not a suicide risk anymore. Boundary precautions, oh my gosh. If you think it's anything like, oh my gosh, you've got to be watching these guys all the time. especially if there is a mental illness, because sexuality really comes into play. They're promiscuous, have no boundaries, and you need to set boundaries for them. They will watch the child for inappropriate physical or verbal interactions with others. Don't assign a roommate for that exact reason. You think, oh, put two girls together. That's not even an option. They don't get a roommate. Things can happen. And then it's restricted on the unit to the child cannot gain entrance to that. They can't have visitors. It's very restricted. Their typical day is basically they get up, they go to group, they go to their own counseling appointments, they go to art group, there's a physical activity because physical activity burns off energy, visiting, phone calls, and then reflection time. Use of restraints, just think about this. It's usually a last resort because we don't want to do that. Pediatric deaths have been associated with restraint use, so that's why we're not big on that. We may have to, but we try not to. Seclusion is a possibility. There is a padded room at that facility, and they will put them in there if they are causing harm to themselves or others. Remember your mental health approach. Safety of others, safety of yourself. Keep your back to the door, right? You want to have an escape route when you're in a mental health facility. Nothing on you, right? You're not bringing something around your neck. You're not wearing jewelry. Don't do that. You know that. Play therapy we use a lot with kids. Art therapy, music therapy. They play a lot of games that could be pet therapy as well. Cognitive behavioral therapy. We use board games a lot. Weighted vests, socks. Could be a weighted blanket as well. Just for tools for therapy. What else have we got? Learning disabilities. With learning disabilities, behavioral challenges and stress, these kind of things. Some of the biggest things is to think about an intrauterine condition. So cigarette, alcohol, and drugs with mom. This can affect the baby long term. So our NAS kids, genetic, environmental factors, comorbid ADHD or autism can also cloud this picture. 1/3 of individuals with learning disabilities also have ADHD. Learning disabilities are more common with boys. Be patient, assess the learning need, ask the child how they learn best, and design learning interventions accordingly. Are they a reader, a listener? Do they like to touch, play with things to learn? That's what we are asking them. Be an advocate for the child, get thorough testing done, get an IEP. So IEPs are for high school and kids in elementary school. IEPs become ADA accommodations in college. So if you need an ADA accommodation, please let us know so that we can get you extra test time or whatever is needed in the learning environment. No shame in that. Being hearing impaired, I always had an ADA accommodation during college. It was not brought to the attention of the school of my hearing disability until 8th grade, so it was too late in the system. I did not need accommodations at that point. All I needed was to be treated like normal. In the college environment, I did not need a lot of accommodations. It was more like note takers so that I could pay attention to the instructor's lips and lip read. So every kid is different. You got to ask them, right? You can't make any assumptions. You know what assume means. Behavioral problems, with or without a mental illness, that can include failure to complete the directive, failure to initiate behaviors requested by an adult in a reasonable time frame, failure to follow learned rules of conduct, yelling, complaining, defiance, throwing objects, swearing, stealing, lying, arguing, failure to complete schoolwork, engaging in physical fights, refusing to go to school, self-care, being ignored, talking back, and disrupting others. So those are behavioral problems. Some of the things that can cause that: inconsistent discipline, inconsistent monitoring, harsh or lax discipline methods, dysfunctional family interactions, mental health disorder. So outcome, we want less family conflict, less school problems, less issues with peers, less frustration on the child's part or the caregiver's part. And then seek help for caregivers when the behavior is developmentally inappropriate, it's causing impairment at home, school, or with peers, and emotional distress. The nursing interventions that we do with these children: monitor behavior consistently, praise the good, catch them doing good, be consistent, focus on giving positive attention. Defiance and aggressiveness produce the consistency that the child craves. So the more you make attention to them, they're going to do it more, right? Recognize and terminate escalating behaviors, confront negative interactions, provide incentives for compliance, don't regress to name calling or threats, use joint problem solving and negotiation techniques, communicate on positive terms, and identify and reframe your expectation. So this can come out also in hospitalization, right? So in hospitalization, they may regress. They may not follow your orders. So we always have a conversation with the parents about what is the parenting style at home so that we can be consistent with that. If there are boundaries, we want to maintain those boundaries in the hospital. Stress can look like headaches, abdominal pain, GI upset, bedwetting, incontinence of stool, behaviors, anxiety, depression, irritability, anger. So again, our management of that is exercise, burn off before you burn out, journaling, deep breathing, meditation, hypnosis, prayer, talking to an adult or a peer. And then the crisis management is just make sure that people are safe in the area. So in crisis intervention, it's time limited, and the crisis is personal, so the loss of a house or whatever. Safety, having the safety of the patient and involved healthcare professionals. Catharsis, patients in a crisis have an overwhelming need to express feelings, letting them tell their story. Empathy-based listening, help me to understand how you're feeling. Entropy is do not add more chaos to the situation. As the child escalates, the nurse becomes even calmer and softly talking and controlling body language. So don't increase the problem. Personality disorders. So personality disorder, someone with a personality disorder is usually stuck in a developmental age of 7. Their behaviors are learned, maladaptive, and it's an atypical brain chemistry. So it's passed down from generation to generation. Personality disorders cannot be formally diagnosed until after the age of 18 because the brain develop personality development from that. So borderline personality disorder, you remember that. Monitor for suicidal ideation, self-harm, establish a routine, be consistent, don't be manipulated, offer support, encourage individual and group therapy, antidepressants, and medication as needed. Impaired executive functioning, this is your ADHD and learning disabilities. They have executive functioning issues with planning, organizing, sequencing, using memory, self-regulation. So working on working memory and recall, activation, arousal, effort, controlling emotions, internalizing language, and complex problem solving. These children are going to be forgetful. They distort the sense of past events. They have altered sense of time, self-awareness, and future. So we want to be concrete, use visual aids, reduce their workload, give extended time on tests, and increase support and supervision. With attachment disorder, let me just see if I'm going forward on here. Yeah, okay. Attachment disorders, just consider it being parent-child relationship is the future of all other personal relationships, right? So attachment is biologically driven and manifested by the need for touch and to be close to a parental figure. So disrupted attachment occurs when the infant is unable to respond appropriately to a caregiver or the caregiver is not there, right? So some things that can happen with this is feeding disorders, failure to thrive, anxiety disorders, and a reactive attachment disorder. Let me tell you about feeding disorders. In the NICU, we have to be very careful to make sure that the baby has a pacifier, even if they're being tube fed, because they can become oral adverse. So what happens to a normal child when they're being fed? They're being talked to, looked at, right? You're the center of my attention. I'm here breastfeeding with you. Or am I playing on my phone, detached? It can cause a big issue with the child. If they're in the NICU, being bottle fed or tube fed makes a difference. Look at this when you're in the NICU. If you see a person, are they talking to the baby or do they set the pump and walk away? It makes a large, large difference. And a lot of these kids these days are being NICU grads. You will see them caught in this. And it's nothing to do with them. It was the way they were developed. Okay. So just being thoughtful about that. When you think about someone as an adult and how they act, always think what happened to you as a child. That really cues you into their behavior and why they're doing what they're doing. So attachment disorder, the treatment, how they are appropriate or inappropriate with strangers and caregivers. It's a safety assessment of the home, potentially putting them in foster placement to avoid re-traumatization. Provision of an emotionally available attachment figure and limited contact with non-caregiving adult to avoid non-discriminate behavior. So a lot of these things come from a primal wound therapy of attachment disorder. The child separated from his or her mother at birth, loses the mother in the sense of self, and that's seen as the same from the child's perspective. The child will suffer a sense of losing oneself, and it's very hard to overcome, even years later. So some of these people may just not be attached to you, even in the school, even in the nurse's office. They're very detached. This came from birth, right? That trust versus mistrust will get you every time. It comes back to it all the time, all the time. So when someone's not acting normal, think about what happened to them as a child. Your mood disorders, you remember that from mental health. Just a reminder about mood disorders, depression. You can see it in infants as well. We see it all the time in the NICU. So infants have a sad expression or a lack of expression. They look away when they're spoken to. There's a lack of interest in play, problems sleeping or eating, separation, and increased risk of a depressed mom. So in toddlers and preschoolers, we see that as irritability, acting out, suddenly begin getting in trouble, not experiencing pleasure, self-esteem, guilt. And then in the school-age child, you're going to see it as defiant, angry, hopeless, acting inward, withdrawing from other people, or physically having altercations with people. The depressed adolescent usually begins having poor school performance, cutting, suicidal gestures, and communication of depression. So depression is diagnosed in approximately 7% of US kids and adolescents. Persistent sadness, loss of interest in activities. So again, you know that from mental health. Children are less likely than adults to experience psychosis with depression. Mood may be irritable than sad, acting out instead of acting in. Suicide is a real risk because especially male children do not think about it. They get the gun and act. We know this from Montana, and all of my work in Montana was surrounding children and adolescents and not having that ability to executive function. Boys will make a decision and go act on it. Girls will usually tell someone. So you have that key information to be careful on the test questions. If a male tells you that they're going to do something, they probably already have a plan and a means. A girl tells you, they're still thinking about it. They're still contemplating it. So that's always the thought process. With somebody that's depressed, you always want to get the guns out of the house, make sure they don't have access to guns and a means to do it, right? So you're always looking for episodes of depression, family history, lack of social support, a stressful event, current substance abuse, and medical comorbidity. So is there a reason why they would want to do this, right? Okay, a little bit more. Sad faces is the depression scale that we use in kids a lot. So sleep disturbance, inability to experience pleasure, despair, fatigue, appetite changes, concentration, emotional sensitivity, and suicidal ideation. People that have a desire to hurt people, desire to escape a painful home, people who are bullied or abused, somebody punishing themselves because they feel guilty about something. The deterrence of suicide is having family support, frequent check-ins for bullying at school, and having hope of the future. So when you don't see that, we're in trouble. Indications for medication. At what point do we need to have medications on board? The child's not responding to psychotherapy, severe symptoms, history of recurrent depressive episodes, and psychosis. The only caveat with that is some of the meds cause even more suicidal thoughts. So remember that on a test question. If there's ever a chance on the test question that it increases the risk of suicide, that is true. Medications meant for depression can actually make it worse. Okay. So usually our treatment of symptoms with medications, we're going to skills before pills. Always try your therapy first. Always try therapy first. Test question. And then start low and go slow, low dose and titrate up slowly as necessary. That's just good across the board, right? You never want to just dump somebody on a big dose if you don't know what they're going to act like, right? So just remember that overall, understanding medication, you always want to do skills instead of pills. Try the least invasive first. Then, when we do go on pills, go slow and low to begin with. Most psychiatric drugs are off-label for the age group. Suicidal risk may increase in the initial days of treatment because they expected more from the medication. There's also a huge part of noncompliance in this group. Okay. So antidepressants have to take 2 to 4 weeks to work. You know that from mental health. They act on the serotonin, dopamine, or norepinephrine. 60% will respond to treatment. So some of them have severe sexual side effects as well. Remember your SSRIs, those are first in line to treat depression in children. Lexapro, Zoloft, Prozac, but they can also cause serotonin syndrome. Remember serotonin syndrome So remember, MAOIs and SSRIs can't be given at the same time. Remember all that stuff for mental health? It's not going away, it's coming back. You can actually get a lot of help from mental health on these questions if you were to get it. Again, just look through this stuff in your book. It's totally pretty equal to adults, other than, like bipolar mania could be rage instead of the normal bipolar. So a lot of this stuff is going to be the same. Be cautious when ordering medications that are extended release. Librium here and Librium there, same thing, right? So a lot of these things are going to sound a lot of the same. Your phobia, your panic disorders, your post-traumatic stress disorder, chronic anxiety are going to sound a lot alike. Your Librium, remember, being dehydrated makes them more at risk for toxicity. Remember toxicity in Librium, drawing blood levels frequently, looking for suicidality. Your chronic anxiety, where is the anxiety coming from? Obsessive compulsive disorder, same as adults, but obsessive compulsive disorder is also a comorbidity with personality disorder, Tourette's syndrome, autism. A child might experience dissociation, depersonalization. The biggest thing with obsessive compulsive is don't interrupt the ritual. Instruct the child how to complete thought stopping. Give them relaxation techniques and cue cards. Phobia is avoidance, and usually that has to do with school for a reason, right? Think bullies. Your panic disorder, your PTSD, flashbacks. Again, some of that in teenagers is going to be a sexual nature, a childhood abuse, those kind of things. So be careful when you trigger memories. What theory of personality disorder describes the patient as stuck at a developmental age of 7 years old? What did we say? What did we say about that? So 7 years old, developmental age. Developmental age could be a key element of this question. So that theory is psychodynamic or developmental. Okay. Dissociative disorders, again, just like your mental health for adults, children were also talked about at that point. So dissociative and amnesia. Somebody might have dissociative amnesia when they are having issues at home, a horrific abuse, horrific memory, whatever that is. Usually dissociation is easy for children from 2 to 7. They develop magical thinking. They'll have made up friends and situations. Remember that? So some of these things that are labeled dissociative is dissociative anemia, amnesia, the inability to recall. Unexpected travel away from home gives them fugue. Depersonalization disorder is detached from one's body. So that's actually helpful when we start IVs and things like that. They can actually depersonalize from that situation. Identity disorder, dissociative disorder not otherwise classified as any other disorder. So things that we do for this: CBD, CBT is behavioral therapy, dissociative therapy, cognitive therapy, eye movement desensitization reprocessing, and then some medications as well. So you can look that up. ADHD, again, we're going to give them speed. We're going to give them amphetamines. So children who do not respond to treatment may not be taking the pills. That's a big key for you. Individual therapy, behavioral therapy, emotional support, self-esteem, pharmacology later. Remember, therapy over pills. But this is where your Ritalin, your Adderall become important. Could be a patch, so consider patches. Where are you going to put those so they're not identifiable by other people and kids? And how are they not going to come off and get stuck to another child? School-based interactions, having the child sit near the teacher, a peer helper, a daily schedule, allowing extra time for assignments, giving shorter assignments, giving directions one at a time. Color coding folders, things like that will help them. Help them organize their desk. ODD is oppositional defiant disorder. So defiance, just consider that. That's a persistent pattern of disobedience, argumentativeness, angry outbursts, low frustration, low tolerance for frustration, and blaming others for misfortune. They will have trouble with peer and social interactions as well as teachers, and usually have conflict with adults. So always ask yourself what happened to them as a child, and you're probably going to get the answer. So there's defiant disorder and there's conduct disorder, right? So the key difference between those is that ODD feel remorseful when they break the rules and hurt someone. Conduct disorder have no empathy for doing that. Impulse control, the failure to resist the urge to steal things, feeling of tension before the theft, the pleasure and relief after the theft. So impulse control disorders, kleptomania, pyromania, intermittent explosive disorder. Different than, a kid playing with fire. That's one thing. But if they're always thinking about it, intentionally setting the fire, that's when it needs to be psychotherapy, aversion therapy, and SSRIs. So think about that. I don't know of anybody really who hasn't had to come in contact with a kid that has one of these issues. It's just, there's a place for fire being set and watching the fire. And again, obviously, if you're up north and you go camping a lot, that's a natural thing to happen to kids because they're around it all the time. But does that mean I want to set my house on fire? Right? So there's a difference. Consider antipsychotic medications might be used, Zyprexa, Risperol, schizophrenia in children. Schizophrenia, remember that from mental health. Marked impairment in social and school functioning, disorganized speech and behavior. So again, think about symptoms of schizophrenia: social behavior, language, emotions, perceptions, and thinking. So if you just remember the acronym SLEPT, that will help you. Hallucinations, delusions, cannot be validated in reality, exaggerated defense mechanisms, compensation for feelings of little worth, and 3 phases in hearing voices. Startling, the person is disturbed by the voices; organizing, coping; and stabilization, accepting and integrating the voice into life experiences. So hallucinations. So there's a real difference in that, right? Because children sometimes have difficulty distinguishing between reality and imagination. Children that have been abused may often imagine that they see or hear the abuser. So kids in mental health, it's really hard to tell. Is it a developmental thing? Is it truly a mental thing? So they may not be caught until very later on in life. So nursing interventions with the child with schizophrenia would be a safe sleep environment. Remember, no caps, locked windows, adequate supervision, minimal stimulation, help them with ADLs, encourage them to sleep and drink, eat, um, reality testing, social skills training, behavioral modification, family education, medication education, and antipsychotic medications would be a dopamine blocker. So again, extrapyramidal side effects from adults, also with kids. So tardive dyskinesia, involuntary muscle movements, tremors, things like that still come into play with kids. We would use Haldols, Apraxia, Risperidol, Seroquel, clozapine. So just remember neuroleptic malignant syndrome, metabolic syndrome, and a child taking antipsychotics. Emphasize the importance of continuing the medication, making sure that they're taking it and that it's going to take 2 to 4 weeks to get active in the system. Monitoring for all the metabolic syndromes and everything that's going on. Provide family and patient education regarding side effects. And that leads us into autism. Autism disorder. Multiple causes, including genetic, biochemical, and environmental factors. So it's usually pervasive, severe social skills, communication, emotional attachment, and repetitive behaviors or activities. 10%, it's the fastest growing pediatric disability. So kids with ASD are more likely to be born for women 35 years or older and born breech. Consider that we call anybody over 30 basically geriatric when they're having a baby. So they're already at risk. Defects or deficits are usually apparent by 18 months and the disorder diagnosed before age 3. Genetic mutations have been discovered. Parents usually report concerns about interactions with other, language, and play. They don't talk or babble by year 1. They don't respond to their name. They don't seem to be able to hear. Violent tantrums. So again, there are a lot of screening tools for this. Early intervention, big time. It's a sensory processing disorder. So it's usually highly sensitive to lights that are extra bright, extra loud noises, even mild tactile stimulation seems to be like a big push or a shove. So think about that when you're doing a physical assessment. Some nursing interventions, early intervention, family therapy, short periods of exposure to stimuli to build tolerance, massagers, vibrating toothbrush, aromatherapy, weighted vests, clay, seeds, sands, small soft pom-poms, anything that are stimulating to touch. Lava lamp and toys that encourage motion like a rocking horse or a trampoline will help as well. Think about sensory processing disorder, especially in NICU kids, right? If we are not sensing and touching them like normal children, this may be some of our concern with our kids in the NICU as well. So eating disorders, again, like adults, anorexia, bulimia, and compulsive overeating. So looking for focus on dieting, skipping meals, going to the bathroom after they eat, diet pills, laxatives, excessive exercise, extreme counting calories, and negative comments about self-body image. If you consider that as girls and boys, we start very early on talking about what's acceptable and what's not. They're seeing their parents doing dieting techniques. They are in high competitive sports that require them to lose weight or gain weight on a moment's notice, ballet, dancing, gymnastics, right? It's easy to see where this could go wrong. It's also easy to see that this might be the way to get control over a parent. So there's a lot of thoughts around children and control and divorce and separation and things like this, right? So we know that this is true. We know that this is able to happen in the child. So these same things are going to sound a lot like the adult because we usually start them earlier on. Remember all your stuff from mental health. It's going to come back. So remember anorexia, remember bulimia. Anorexic, remember electrolyte imbalance, lanugo, you're monitoring their behavior. We're trying to do therapy before. If we need to, we will put in an NG tube, we will put in a feeding tube. A new kind of this thought process around anorexia is also diabulimia. If you look it up online, there's a lot of studies coming out of Europe. So we now know that insulin dependent children, type 1 children, type 2 adults, may be using their insulin against us. If we play a game of Russian roulette with our insulin, we can make things happen to our body. So now there's a whole series of studies coming out about the use of insulin against the patient, right? So you may even have to observe insulin injections by the patient as well in this thought process. These guys, if you do work at a eating disorder clinic or a mental health facility that does this specialized program, you're going to be constantly putting them on the scale. They weigh in backwards, and you make sure that they spread their legs and drop everything because they know what you're expecting to see on the scale, and they may put things in their vagina or rectum or under their arms to make them weigh more on the scale. So this is a full out, need to make sure that they're not doing anything, make sure that they're not using laxatives, vomiting, over-exercising, sneaking food. So you know this from mental health, this is very similar. Compulsive overeating, again, same thing, right? They're in the same way. Substance-related disorders, again, almost the same thing as adults. Remember that a lot of teenagers are not thinking yet. They're thinking and they don't see the outcome of what they're doing. They won't see it for years, right? If they saw it right away, they would be able to rationalize it. So in your book, there's a lot of stuff on this. Just remember the CAGE questionnaire. So have you ever felt that you should cut down? Have people been annoyed with you? Have you ever felt bad or guilty about doing it? And have you ever had an eye opener in the morning and study your nerves or get rid of a hangover? So remember your CAGE. That's still available for child use and teenager use. Peer family substance abuse, so it could actually be their parent providing these things for them. So we have to think about that as well. The time of ingestion for a drug being detected in the urine is in box 15-1. Remember this. Think about this. Now that more things are becoming legal, there's less that we can do about it. But obviously, if it's a child, it's still child abuse. Think about methamphetamine. Some of the unknown survivors of that are children. we tend to find medications, drugs hidden in ER visits. So an ER visit of a child that's very stuporous could be drug ingestion. Kids don't know any better, and they go along surfaces and they touch and they lick their hand, and now they have drugs on board, right? So you're always thinking about that behind the scenes, behind your mind when you have a kid in the ER. If the kid's just not acting correctly, they may have gotten into something the parents have hidden. It is typical in the US when the police get to the house and they're raiding a house for drugs that they'll go into the kids' room first, because that's the first place cops will not look, right? They're always going to go to the parents. So they know that and they'll hide it in the kids' room. Unfortunately, the kid gets in there and gets in trouble. Okay. Vaping, again, we've already kind of talked about that, but that's again becoming a bigger issue. Gum, patches, Wellbutrin, but we can always use things. We can use hypnosis, acupuncture, aversion therapy. Caffeine, it's the going thing, right? Every kid, when they're like 10, starts drinking coffee. Is that the right thing? That's a thought process. Nursing interventions for children withdrawing from caffeine include telling them the ill effects of caffeine, assess for other uses of other substances, and provide education, support, and encouragement. Inhalants, gasoline, glue, anything from a can that has propelled compressed air. So cleaner fluid for computer keyboards, also known as huffing, sniffing, bagging, and these substances quickly cross the blood-brain barrier. So kids might cause mouth ulcers, confusions, headaches, and GI disturbances. So looking about that, nursing interventions, markers, things like that can also be used for huffing and sniffing. Oh my gosh, there's lots of things out there these days. I never knew things were possible, but bath salts and all kinds of things, right? So you just always have to be aware of new things that are coming out. Most of the time, we can try to get them in teenage groups and therapy for alcohol and narcotics and things like that. You're just looking always for a sign of relapse. Sometimes we just need to send the whole family. All right, which of the following is appropriate intervention for a patient with OCD? Interrupting the ritual, instruct the child on how to complete thought stopping, refer a child to cognitive behavioral therapy, reassure the child that you won't leave. OCD, do not stop the child, right? So thought stopping instructions. So don't interrupt the ritual, that'll make them more anxious. Instruct them on how to stop thought processing. So the child becomes aware of the thoughts and then tries to stop them. Relaxation and cue cards. So one more thing in this chapter that we need to go over is childhood abuse. So the risk factors for neglect include substance abuse, high levels of stress, unstable interpersonal relationships, and lack of social support. So you can read in your book as well, but some of the things we haven't talked about yet. Munchausen by proxy. Munchausen syndrome by proxy, also known as fictitious disorder imposed on another, is when a caregiver, usually the mom, attempts to make the child appear ill. So they may put blood in the child's urine, stool, or vomit to make up symptoms for a healthcare provider to see. They may be admitted to the hospital with diagnostic tests. And if so, that child should be placed in a room with a camera so that the caregiver's actions can be monitored. We do this. So there is usually a monitored room, one monitored room minimum, in a pediatric unit. And that's where we put the failure to thrives, the questionable kids that we're double checking. Is it mom or is it the child? And are they really having those issues? So cardiac issues, seizure issues, things like that, we usually put them in a monitored room for a reason. We don't always tell them there is a video in the room, right? If we're trying to catch them. So this day and age, we actually have monitors that are able to be wheeled in and out of rooms. So you can call upon that technology if you have it in your facility. We did use that in Montana, and we used it multiple times, especially in people who had snuck pills. Anybody we were questioning on, we would go ahead and throw the camera in the room. It was able to be taken away from the room or put in the room and started and stopped remotely as well for monitoring purposes. So just know that that will be or potentially be a test question. Marchism by proxy is something you need to know about with pediatrics. Recommended treatment for abuse victims is stabilization and then therapy, removal from the home or the offender eventually, if needed, and then assessment for future psychiatric disorders because of the abuse. Any signs of physical abuse, including bruises, lacerations, especially on areas covered by clothing, marks of objects like belts, ropes, hands, cords, bite marks, bald spots, aggression, fear towards individuals, indiscriminate seeking of affection, and defensive reactions, question them about those injuries. So typically a test question, at least one or two questions on the NCLEX will come up about child abuse. Always ask yourself, plausible, not plausible. The other part is we need to ask the child, right? We're not going to ask them with the parent present. That might be an issue because the parent might not want to leave the room. Find a reason for them to leave the room, right? In maternity, in labor and delivery, we usually take that option as the guy going downstairs to get the car seat for us. We'll take 2 minutes in the bathroom with her and ask 4 questions. Any drugs? Anything you need to tell me? Any social history? Right? Anything you need to tell me. Because we want to have that information sooner than later. We also ask, is there anybody that does not need visiting permission, right? Think about this in pediatrics. There might be people that are trying to get in to access the child when the mom or dad is not there. So security taken to a whole nother level in maternity, whole nother level in pediatrics. The same thing that you learn about with infant alarms is the same thing in children. If mom and dad are not present, if we are not a locked down unit, there will be an alarm on the child. We have constant eye contact on kids and potentially camera at the front door with an ID and a password, just like labor and delivery, because we need to maintain control over these kids. We don't know what's going on in their home life all the time. So think about that. Also, the whole thing with fight, flight, help. If you have somebody show up with a gun, what are you going to do? That's always a training that we do every day, every year. You have to do it. It's a thought on your mind all the time in pediatrics because you don't know what's going on in the families. You don't know what's happening in their lives necessarily. So in Montana, we actually had a situation where someone was on the sheriff's department was looking for them. The parent, the male parent, had been in contact with the parent, the mom, on the phone and threatened her life. They came into the hospital and were seen with a gun. They left the hospital and were shot outside the hospital. They showed the police the gun and they were trying to kill the cops outside the hospital. So these things happen. You cannot take for advantage that we're just in pediatrics, nothing bad can happen here. You just never know. So always be on watch. In this chapter, we covered a little bit about mental illness. We went back over mental health, pediatric mental health, the assessment, the care provided, personality disorders, learning disabilities, executive functioning impairment, attachment disorders, mood disorders, associative disorders, dissociative disorders, disruptive disorders, impulse control, autism, eating disorders, substance abuse, and a little bit more about childhood abuse.